Hello, this is your brain on drugs, and this is the punk rock psychiatrist. So today, continuing my series of update episodes, we had one in July, did one, I had a two-parter in September. This one's actually this November one, so we're doing about every other month. I felt like stuff was stacking up and wanted to talk about some of these interesting things coming out since the last update episode. Let you know some of the most important articles in psychiatry that have come out, and discuss new meds that might be coming out, um, new indications for medications, and just exciting psychiatry stuff. Um, this is longer, but I don't, we'll see how long I talk about it. The purpose of this episode is kind of just to go through stuff, not discuss the articles. And I was kind of thinking, once I get through all the material and I'm kind of running out of stuff to talk about, which will probably be several years from now if I keep this up, I might do deeper dives on the updates. But, a lot of these updates are things that we will get to in the future. But I thought, since this is hot off the presses, why not discuss it now? So without further ado, let's get into some November updates. So my first update is not necessarily something hot off the presses, but it's new information. This is another thing I wanted to use these update episodes for would be to talk about things that we've already talked about, but that I have additional information that I found out. So we did all the antidepressants in the first season, and I talked about vortioxetine. I even had a ranking tier list that I came up with, and I had put vortioxetine in the D tier. I just not that impressed that it adds that much more to the table for the cost. It just seems like a fancy SSRI that maybe offers some improved nausea, but even then, I've seen a couple of patients on it, and they told me that um, I mean, one said their nausea was worse, oddly, and another one said that their nausea was no better. So the 5-HT3 blockade that it has, I'm not sure. It would be nice to have some studies that told us more information about that and could actually give us data rather than anecdotal reports of a drug that I just don't use that often. All right, but I did find out some interesting new mechanisms of this drug, and I wanted to talk about it. And I might move it up to, I don't know. It would depend how effective some of these new things I found out were, but maybe tentatively move it up to C tier, and potentially put it in B tier if this stuff is actually plays out. And if not, I leave it squarely in D tier, right? So, um, some cool stuff that it does is it modulates something called PPAR. I think gamma. I have a little Y there. I think that's gamma. Which so there's a lot of anti-inflammatory. So basically, like this medication has a lot of anti-inflammatory properties, and it does it in a lot of different ways. And one is through modulating PPAR gamma, um, anti-inflammatory and immunomodulatory, which in a way affects inflammation. Um, it also promotes anti-inflammation shift in the microglia, which are cells in the brain, from the M1 to M2 phenotype via the 5-HT2B and 5-HT7 receptor activity that it has, perhaps. Um, However, there are many antidepressants actually do this, which is something I'd never heard of this shifting microglia M1 to M2 phenotype. This is nothing I had ever learned about, heard about. What is it to be in an M1 phenotype? What is it to be an M2 phenotype? I guess these microglia cells can go from one type of phenotype is kind of like what it looks like. Um, so it kind of like I guess the way it's arranged can go from an M1 type to an M2 type, and a lot of antidepressants do this apparently, and lithium and ketamine. So vortioxetine is not necessarily better or different, but it also does do this. But it also has that PPAR gamma, and I'm not aware that any of the other medications have that effect. It also modulates NFKB pathway, which reduces expression of TNF alpha, IL-1B, and IL-6, and those are inflammatory signaling cytokines. I believe those are cytokines, but I mean those are inflammatory signaling things. People that have autoimmune diseases, they take medications that counteract TNF alpha, the IL-1 and 6. Also, so many antidepressants also have this effect, including fluoxetine, sertraline, and venlafaxine. So also not necessarily unique to vortioxetine, but something that you may not have heard of. And this may be one way on how just antidepressants in general work, is through some of these anti-inflammatory pathways. So not just their serotonin reuptake inhibition. All right. And then also, and we're talking about vortioxetine here. It does all of these things. It's got some COX-1/2 inhibition, which is like an NSAID, right? Um, and from what I've gathered, it's actually stronger than most NSAIDs with fewer adverse effects. So perhaps it doesn't cause the risk on the stomach, but it has this inhibition. And that might be that it has more COX-2 than COX-1. Um, you know, we'll probably talk about the NSAIDs, and one thing that differentiates one NSAID from another is how much COX-1 versus COX-2 um, inhibition do they have, versus how much cardiovascular risk versus um, risk to the stomach lining does it have. So apparently vortioxetine has inhibition on these COX-1 and 2 with fewer adverse effects. I don't know. I'm just kind of guessing. All I could find was fewer adverse effects. There was not really details there. And I'm not what I could not find that other antidepressants had this effect. I also could not find that they had the PPAR gamma effect. It's also shown promise in treatment of long COVID, which is kind of a interesting syndrome, which we hadn't seen before COVID. And so because of this, this is in long COVID, is somewhat related to fibromyalgia, which is somewhat related to chronic fatigue syndrome. Like, a lot of those conditions are kind of related, and we don't necessarily know what they are or know what to do for them. And perhaps vortioxetine might be a good option if somebody has chronic inflammatory state, like they have an autoimmune disorder. Perhaps this might be a good option as an antidepressant for them, because it may also help with the other condition they have. And maybe just in general, inflammation in the brain is bad for mental health. So I am cautiously wanting to increase the tier of vortioxetine. However, one reason why I haven't really used it is because in the military system, this is a drug that is not really, it's a non-formulary medication, meaning that we have to basically have the patient fail 4 other medications before we reach for one like this. And honestly, if 4 medications have not, if 4 standard antidepressants have not worked, is this one, which is nothing more than really another SSRI. The one thing I might think about vortioxetine is, might it have less side effects? Is it going to be more likely to actually work when it basically is an SSRI? Probably not. It may be that if they didn't tolerate other meds, trying this one might be a good option. But like I said, if you've failed that many, and the thing is, I'm probably not even gonna give a patient 4 different antidepressants to fail. I'm probably going to be moving on to antipsychotics or mood stabilizers, or thyroid hormone, or something else out of the box. I'm not going to give them like a million SSRIs. So the opportunity for me to use and then especially after we've failed that many, I'm probably going to use one of those other things and not another, basically an SSRI. But oh wow, I can use this one now because I've failed 4 trials. So for me, in the place I worked, it just wasn't an opportunity to use it. If this thing goes off patent and becomes on formulary, it would be one that I would try out and say, I think one interesting piece of advice I got when I was a resident was one of the staff, and he was a recent graduate. I think he had basically his first year as a staff, and one of his he gave me actually he gave me some of the best. If you're out there listening to my show, maybe you'll remember that you gave me this advice. But he gave me some of the best advice that I ever had, and I'd say this podcast may not be happening right now if it wasn't for the advice that he gave me. He said to me, and I was struggling with a lot of the stuff. Like, it was hard. Psychiatry I'm a logical person, and psychiatry, especially the way it's taught, it's not the most logical thing. It's it feels like either you're reading a script, which is unnatural when interacting with a patient, or you're just good at talking to people and you can follow this script without following the script. And I'm a very logical person, so I'm going to follow the script. And I think as a physician, when you're interviewing a patient that's not in mental health, it just makes more sense to kind of go through a review of systems and be like, do you have this? Do you have constipation? Do you have pain when you walk? Do you have a normal, pace? Whatever, like, and you're going through a series of questions, and the patient is assuming, like, they're like, something's wrong with me. I don't know what's wrong with me. It feels out of my control, and I want you to figure out where it is. And so the doctor can go through things like this. But and this is more the way my mind thinks, And so then in mental health, it's more like you're having an interview with the patient. You're finding out about their life and what their social, what they do with their, their time off, and how they feel about different things, and what their relationship were with different people throughout their life. And but at the same time, you're gathering substance use history, and you're gathering family history, and you're gathering social histories, and you're trying to do it in a natural way that's more like a conversation. And I think for a lot of people that are, maybe more extroverted, or just like more, just more capable of doing that kind of thing naturally, that comes easy to them. But for me, not so much. It took me a long time to learn how to do an interview. And so I especially and I was an intern when I got this advice, and I was just struggling with it because I wasn't used to interviewing like this and asking these type of questions. And also, you have to be very sensitive to patients and show them empathy. And I had a hard time with the empathy piece, showing the empathy, because I'm just such a logical thinker. And so, like, I wasn't feeling what the patient was feeling, and I wasn't pausing and saying, oh my gosh, that sounds horrible, or that must be so difficult for you. And to say it felt so fake to me because I wasn't feeling it, because I don't know, you see so many patients, and you can't get involved in the emotions of all of their lives. So it's just, and it becomes the same story over and over and over again. And you become desensitized to it. And so, like, it just doesn't, sometimes things shock you and they're like, oh my gosh, that sounds terrible. And then it's like real empathy that I don't have to like conjure up. But a lot of the time it's like, yeah, I've heard this 1,000 times, but at the same time, it's still awful. But to have like a natural response to that, I'm not an actor. I'm not very good at hiding things. So I don't know. Regardless, I was struggling with a lot of things. And his advice to me was, what you need to do is get really good at something. Find out what your thing is. What's your niche? What are you going to be concentrated on? And get really, really good at that thing, and be better than everyone. Spend so much time on that thing that you're better than everyone else at that thing. And then people come to you for advice for that thing, and then they will overlook a lot of your deficits. And the thing is, with time, those deficits will improve, but like those were weaknesses that I had. And so I actually chose medications. I chose to become better, to learn things about meds that no one else knew. And I was like, this is, this whole pharmacology, chemistry stuff, that's what makes sense to me. This is something I feel like I could grab onto. I'm going to get every paper that talks about it, every book that talks about it. I'm going to read everything. And I knew more than most of the staff as an intern, to be honest with you. Um, I just, in my experience, psychiatrists don't know these things. And that's why I'm having this podcast. For those of you that, you know, you don't know it because it wasn't part of your residency. They taught you, oh, this is an SSRI and this is how an SSRI works. But did they teach you about how some of them affect dopamine more, some affect anticholinergic receptors more, or 5-HT7 or 5-HT1A, or did you learn the details of this, or did you just learn, hey, these are all pretty much the same, just use whatever? That's what I was taught. I was very unsatisfied with that. It seemed like to me the most critical thing that we were taught, which was giving a drug to a patient, the opportunity to cause the most harm to a patient by giving them a drug, was the thing that they just kind of made seem like it wasn't that big of a deal. And what's crazy, if there's folks outside psychiatry listening to this, um, you, these folks are really afraid to use our meds. Like other professions inside medicine, like other doctors, they don't want to use antipsychotics. They don't want to use mood stabilizers. They don't even want to use antidepressants. They will send us patients to us just to give them an antidepressant. And I'm just like, and it's just so funny because the danger of these drugs are just like, it's not really emphasized to us. And other professions are afraid of them, and I think they're right to be, because there is a lot of bad stuff that go. I remember asking this internal medicine doctor, I was like, why, what are you worried about? And she listed off all this stuff. Well, this could happen and this could happen and this could happen. I was like, oh yeah. And I'm just like, I'm not really taught these things as in psychiatry. I'm not really taught these things. You're taught about these things, but then you're not taught like what to do about it, because you're assuming that the psychiatrist is the expert that's going to look out for these things. And in many cases, they don't, because it's just like, oh, well, use these a million times. It doesn't matter. Just pick one. Just use this one every time, whatever. Um, and that's what this podcast is about. It's about like teaching you not to do that. And so I told you that the advice to staff was to get good at something, and I chose this. And I would say that over 10 years of developing this material, it ended up in this. I ended up gathering so much information that I had years and years of information to teach in a podcast. So I thank you out there, um, for giving me that advice. And I brought that up because he gave me another piece of advice. His other piece of advice was just use everything. Don't just stick with one med. He was like, have you used Prozac before? Give him Prozac. And I was like, but doesn't it matter? And I think maybe it could, but I think his perspective was, I'd never used it before. And there are very subtle differences between them. And it's important that I see how a patient responds to Prozac. I should be using lots of Prozac and lots of Zoloft and lots of Celexa and lots of everything, lots of Effexor. And, one reason why I don't use Effexor anymore is because I used it a lot and I did not like what I saw from it. And so I don't really use it anymore. And I think with vortioxetine, I think it's important for us to use it so we can see kind of when it makes sense to use it. Because like theoretically, there's all this cool stuff about it. Like I'd like to go to vortioxetine, maybe first or second line if I'm sensing that some anti-inflammatory properties might be particularly good for a certain patient. But when you're in a system where you've got formulary and non-formulary, they're not going to approve it. And I think that's good because it saves the medical system money. But it's bad because now you've got a provider, me, 10 years later, who's never used this medication. I've had a couple of patients who have taken it in their history, and I've interviewed them about that, but I've never prescribed vortioxetine. I'm out there as like the punk rock psychiatrist medication expert, and there's probably residents out there like, I prescribe this. It's like, well, in the military and training from 2012 to 2016, um it just wasn't. It came out, like 2015. It came out towards the end of my residency, and then I went overseas, and it just wasn't stocked in the pharmacy at all, and I spent the next 6 years there. So I mean, the opportunity for me to use it just really didn't exist. But I'm conveying this information to you, and I'm honest about what I've used and what I haven't used. All right, so that was a lot longer than I was expecting to talk about vortioxetine, but I'm intrigued. So, and I give you, and I will give. I wish I could remember his name, but I give you all this advice. If you're struggling, find something that you can get really good at, and also use everything. So you know what it does, and then you can know what works the best. And then you'll be like, I've used this a lot and I haven't really noticed much good out of it, so I won't use it anymore. Or this one really seems to work, so maybe I'll use it more often. So I think that is great advice. All right. Our next piece that we're learning in the updates is about pramipexole. So this is a paper entitled Pramipexole Augmentation for the Acute Phase of Treatment-Resistant Unipolar Depression, Placebo-Controlled Double-Blind Randomized Trial in the UK from the Lancet Psychiatry 2025. This is a study where they're using pramipexole in addition to an antidepressant in treatment-resistant patients. So that's patients who basically have taken like several medication trials and not gotten better. They have unipolar depression, so MDD, 151 participants. They failed at least 2 med trials, but realistically, it was actually 3 to 4 on average that they had failed. Their QIDS, which is a depression scale, actually dropped from 16.4 to 10 in the pramipexole group and 16.2 to 13.8 in the placebo. So that is, a difference of 3.8. That's pretty substantial. And that was after 12 weeks, effect size of 0.9. So, I used pramipexole in one patient like 8 years ago before I had heard anything about this, just thinking, well, it's a dopamine agonist. That might do something. This person seems like unmotivated. I had him on Wellbutrin. I was like, what about adding some pramipexole? I tried it. It didn't help. I stopped. But so we're seeing more and more that pramipexole is like getting some positive data for depression as well as bipolar disorder, in an effect size of 0.9. Like that's almost unbelievably high. And that was a pretty substantial drop in the score. So this is one to consider. If you've got a treatment resistant patient, maybe you've gotten a little bit of mileage out of one of the antidepressants, but there's still moderate to severe symptoms, maybe you try adding pramipexole, see what happens. There's risks with this medication. We've seen that, in Parkinson's patients, they get those impulse control disorders where maybe they're like, doing sexual things overtly, or they're gambling, or they're like spending their money on a bunch of junk. Also, we see things like in a restless leg syndrome, pramipexole is now like basically not recommended to use first line, and maybe even like consider not doing it second line, and be very cautious with it because of the effects of augmentation. We'll talk about this when we talk about insomnia. I'll probably do insomnia as the next series. But what happens with the augmentation is that like you need higher doses. It's not working as well. and patients ended up on like really high doses of pramipexole. And the recommendation now is essentially like you can use it, but like don't go to these high doses anymore. And so I would be cautious with it because it does have these risks. But like, if you've got a patient who's not responding to anything in depression, and that, this is a patient whose life is essentially ruined and maybe they're going to kill themselves, taking on the risk of adding pramipexole when you're not sure what else to do is a completely reasonable thing to try. So, um, this is just, this is a paper that just came out that gives us further information. I mean, 0.9 effect size, like I'm pretty excited about that, to be honest with you. So you might want to consider adding pramipexole to your arsenal for unipolar depression and treatment resistance as an augmentation agent. All right, let's keep going. There's a med we haven't talked about yet. It's in my schizophrenia series that we will get to at some point. It's currently, it'll either be taken out because it will not get approved by the time we talk about it, or it will be approved and it will have a name. Right now it's called Alto 101, and Alto is the company, so that's always where you get the letters from. Alto 101. So the FDA actually granted fast track designation for this medication. It is a small molecule phosphodiesterase 4 inhibitor. So it's one in many of new exciting treatments for schizophrenia that don't directly go after dopamine blockade. And they're trying to get it approved for cognitive impairment associated with schizophrenia. So not necessarily the schizophrenia itself, but the cognitive impairment associated with it. And, I'm not really aware of any medications that are phosphodiesterase 4 inhibitors. The medications for erectile dysfunction are phosphodiesterase 5, right? PDE5 inhibitors, but this is 4. So I'm not aware of any current drug that's even uses this mechanism. So hopefully it works because, cognitive impairment is a problem. So just kind of throwing that out there, that there might be something on the horizon for that. And, the FDA granting fast track designation, that is a sign that the FDA is really like, that's because it's like, okay, this is something that is treating something that nothing else treats, and that looks like it really could work. And so it tries to get it to where it can be approved a little bit faster. But of course, they still measure like its safety and effectiveness. Right. All right. Next, I got a couple of articles on Tramadol. And it's interesting because I just heard something cool about Tramadol. And now I see these articles saying, be careful with it. It's a Schedule 4 controlled substance. It's kind of like an opioid. People think of it as like, opioid like, it affects mu, but not to the degree that, like hydrocodone and stuff does. So it's thought of as being safer, but like we've been down this road before. It was like, oh, they thought oxycodone was safer than morphine. And then it was like oxycodone mixed with acetaminophen is safer. And, and then, Tramadol is safer. And it's like, but none of these are. They all have the same risks. But that also doesn't mean that we never use them. Okay. I actually I was listening to a really interesting podcast on a lot of sexual dysfunction in women type of stuff. And they had recommended Tramadol is one option for treating dyspareunia, which is painful sexual intercourse for females. And I thought, oh, I've never heard of that. That might, and I see this, right? Like this is interesting to me because, and I think a lot of psychiatrists, maybe they don't ask enough, but like sex is like a huge part of life, and it's a huge part of mental health. If someone is unsatisfied with their sex life, that has a huge impact on their mental health. That doesn't mean that they have to be having sex or having enjoyable sex to either be pleased or unpleased with their sex life, right? Like you could not be having sex at all and you could care less and you have no interest in it and it's just not an issue to you, and it's not something that you're just like, and you're not even caring if it ever is an issue. And so you're perfectly satisfied with how your sex life is, which is nothing, right? So it really comes down to the patient. Is this patient happy or unhappy with their sex life? If this is someone who is unhappy with their sex life And there may be a reason, like it's painful for them to have intercourse, or it's painful for their partner to have intercourse, right? um, that affects me treating them, right? Because like this could be a primary issue on why they're coming to me and why they're depressed, because the sex life is so important to them and they're not satisfied with it. And so addressing an issue like painful intercourse is something that I would consider doing. Okay, so like this is where, like, I don't know, I practice kind of the functional medicine. I've got little quotey fingers going on there. Trying to find the root of the problem. Right? And, these functional medicine people act like they're going to the root of the problem, and the rest of us aren't. When the rest of us really are, and I certainly am, right? And I wouldn't call myself a functional medicine doctor, but like, yeah, of course I want to find the root of the problem. I'm not just going to throw an SSRI at somebody for absolutely everything. People do that. I don't recommend it. But yeah, if I find out the root of the problem is coming down to painful intercourse, um, that's something that I would not necessarily use, therapy techniques and psych drugs to fix. I would perhaps look at what are the treatments for painful intercourse. And I think another psychiatrist might be like, oh, see your gynecologist. And it's like, oh, now they're waiting another like couple of months to see someone else, and then maybe this doctor is not that inclined to do anything about it because it's not life threatening. And that's why I like to just do it myself. I get educated on it, I figure it out, I do it myself. And so tramadol was something that I had heard could be an effective treatment for that. But um, let's talk about a couple articles that talk about some things that you need to be concerned about tramadol. So this is an article entitled "Tramadol versus Placebo for Chronic Pain: A Systematic Review with Meta-Analysis and Trial Sequential Analysis." All right, so this is a study that came out in 2025 from MBJ Evidence-Based Medicine. All right, so I don't know what MB is. J is probably journal. So this is a meta-analysis. So this is, a collection of different studies. So 19 studies, reduced pain, but by a clinically insignificant margin. So basically, they're saying that the tramadol versus placebo for chronic pain didn't really work. It, like, the numbers were down, but so slightly that it was like not a clinically significant margin, and it raised risks in quite a bit. So the odds ratio was 2.13 for cardiac events and neoplasms. That's cancer, or cancerous growths. They could be benign, neoplasms. Um, but 2.13. I mean, if the risk is super super low, doubling the risk may also mean that it's super low, but that is pretty significant. All right. And then also nausea, dizziness, constipation, somnolence. Those are things we see with all opiates. And patients more likely to continue opioids long term than oxycodone and hydrocodone. So that was interesting. That the patients were actually more likely to continue the tramadol than long term than they were oxycodone or hydrocodone, which we think of as more addicting. So tramadol is definitely not without its risks. And then here in like this meta-analysis of 19 studies for chronic pain, it really didn't work either. So, and of course, we're talking about chronic pain. For acute pain, it may be a good option, but for chronic pain, probably best not to start it, or be a lot more cautious than we were in the past. All right, that doesn't mean that some patients it might not work for, but on average, it's not really making much of a difference. I have another study about tramadol. It's called Risk of Seizure Associated with Concomitant Use of Tramadol and Antidepressants, specifically antidepressants that are 2D6 inhibitors, because tramadol is processed by 2D6 in older nursing home residents, from Neurology 2025. And all these articles came out in like October and November. So There is a seizure risk with tramadol. If you are not aware of that, that is there. And of course, if we inhibit its metabolism, we are increasing its levels, which is increasing the risk of seizures. So this is just, and this is also something for, you may not be prescribing tramadol, but you might be prescribing 2D6 inhibitors. And that's why I generally try to stay away from, this is fluoxetine and paroxetine, right? Those are two of the bigger ones. I generally try to stay away from the 2D6 inhibitors when bupropion is another one. When I'm treating elderly patients, they're just a lot more sensitive to things. They're more likely to take other medications. They're more likely to take things over the counter. And 2D6 interacts. I mean, that 2D6 is probably next to 3A4, the next most commonly pathway of drug in the enzymes that break down these drugs in the liver. So 2D6 is an important pathway. A lot of our meds inhibit it. I mean, the ones I mentioned are strong, but there's ones that are medium and weaker. So that's why I like to use escitalopram in elderly patients. So keep that in mind. And if your patient's on tramadol and you're giving them a 2D6 inhibitor, you might want to consider changing that or talking to their doctor who's giving them a tramadol and having that changed. So this is why it's important to know about other medications. I think, people like to stay in their wheelhouse, and I don't. I like to be in every wheelhouse. If it's drug related, I don't cut patients. I don't stick things in patients. I don't do that kind of stuff. I don't do procedures. And I don't do first aid, life-saving things. I give people chronic meds. And so if I'm chronically giving people meds and they're chronically taking other meds, I darn well need to know what those other medications do. All right? If they're going to use something that's going to interact with something I'm giving them, I need to know what those other drugs do because I need to know what the effect is of the interaction. And I need to try and avoid those interactions. So that's one that you should keep in mind, tramadol for seizure risk. All right, let's keep going. This is an interesting one. This is an article by Lang et al. Doxycycline use in adolescent psychiatric patients and risk of schizophrenia, an emulated target trial from American Journal of Psychiatry in 2025. So this is pretty cool. This is I pronounced that Lang. That A in Lang actually has like a little circle on top of it. So this is a Finnish registry study. So I don't know if that's long. It sounds like it might be a Chinese name, but it's not. It's a Finnish name. And I'm not sure how to pronounce it. So it's a Finnish registry study. 1997 to 1990, or sorry, 1987 to 1997 is the records that they used. 57,000 individuals. I don't know why they went. I mean, that's like 40 to 30 to 40 years ago. Why didn't they get? I mean, this study just came out. I don't know why didn't they use newer data? But 56,000 individuals. And what they found was, and this is kind of interesting. So doxycycline, as you may be aware, is an antibiotic. And, it's used for sometimes skin conditions. So like maybe certain acne. And so this is a medication that like young people might be taking for acne, or I don't know, maybe they have some sort of infection. I don't know, like an ear infection or something. I don't use doxycycline. So I don't know what all it's used for necessarily. But it also has some neuroprotective properties. I'm not sure. I was trying to find the mechanism of that, and I'm not sure where it is. It just says has neuroprotective properties. We may not know. So basically, you had a bunch of kids in psych wards, and some of them took doxycycline for some, antibiotic necessity condition, and the ones that had taken doxycycline, and there were a lot. So this is out of 56,000 individuals. There was like over 1,000 of them that had taken doxycycline, maybe a couple thousand. 1.4% of those kids developed schizophrenia, while while a larger number of 2.1% of those that did not have exposure to doxycycline did also got schizophrenia. So 1.4% of people that were exposed to doxycycline, and this was just like one round. This wasn't like they were on it for like 6 months. This is like they took it. 1.4% of those that took doxycycline developed schizophrenia, and 2.1% of those that were not exposed to it developed schizophrenia. And typically around 1% of the population has schizophrenia, but like if you're in a psych ward as a child, you're probably more likely to be developing or having schizophrenia in the future. And so it's very interesting that if you're exposed to doxycycline, I mean, this is, correlation is not causation, but these registry studies are pretty interesting. And it's a pretty benign medication to take, like, once in your life for like some condition. And so I don't know, this might kind of suggest that perhaps we have people at higher risk of getting schizophrenia. We give them a course of doxycycline while they're 13 years old, and they have this looks like, difference between 2.1% and 1.4%. I mean, that's pretty substantial. That's 0.7% of, you could think that there would have been another 0.7% of kids that took that doxycycline that would have got schizophrenia that maybe didn't get it. And once again, correlation is not causation, but I mean, what's the harm in giving people at high risk doxycycline? It may decrease their risk, and so we might have less people with schizophrenia out there as a result. So I don't know what to do with this information, but I think it's super cool. Like, this is super cool. I really like this. I think we definitely need to be looking more into this. And perhaps, you get to a point where you're like, hey, if you're presenting, I mean, the thing is, kids present with issues, and then like 5 years later, they have schizophrenia, bipolar disorder, or major depressive disorder, or whatever. And in the beginning, it was like they had anxiety and ADHD, right? So maybe you have kids that are popping up with mental health issues, and you give them a course of doxycycline, and you just kind of cross your fingers. Hopefully, if this kid was going to get schizophrenia, they're a little bit less likely to get it now. I don't know. So I think that's pretty cool. Next article. So this is from, this is just one Dr. Brezis wrote this. This was more of like an opinion article, and it was called Failing Public Health Again? Analytical Review of Depression and Suicidality from Finasteride in the Journal of Clinical Psychiatry 2025. This was just kind of a narrative article. I thought it was kind of interesting. Finasteride is, off the top of my head, I cannot remember the mechanism of action, but it is a medication that is used for enlarged prostate. Kind of like the alpha blockers, but it takes a bit longer to work. However, finasteride is known, I think it's Proscar. I believe that is the name of its like branded product. Proscar is one of these meds, but I think it's finasteride for the prostate. But it's known by another name, Propecia, for hair loss, right? So there's a couple medications used for hair loss out there. There's minoxidil, which is a topical, and now actually there's an oral version of minoxidil you can take for hair loss. But finasteride's another one. I've had a couple of patients that one of them was trying to get it, and the doctor just didn't want to do it because I think they just thought that this was for vanity and it wasn't worth spending the insurance money from the military to give this guy finasteride, so he didn't go bald and lose his hair and stuff. And then the other patient was getting it from an outside doctor. Well, the first patient didn't have a choice because they were overseas, so they couldn't really go to an outside doctor. Like, this was their only way of getting it, was to go through us. And I think he was asking me about it, and I don't know a lot about this medication. However, after reading this article, I learned that, and basically the article kind of talks about, we've known for a really long time that finasteride can increase the risk of depression and suicidality, and we're not really like aware of this risk. We're not really educating patients about this risk, and we may be using this medication, and then maybe not stopping it whenever patients have these symptoms. Um, and so basically, it's like failing public health again. So that they're saying that like we should be warning people about this, and we should be warning us about it. I didn't know about it, so now you know about it. Finasteride can cause depression and suicidality. So I'm not saying don't use it, but I think if you're going to use it for hair loss, you might want to think twice, because like, if someone, I mean, losing your hair is not um, really a medical condition, unless it's like um, the areata type or something like that, like an autoimmune, and then you would, I don't know that you'd be using this anyway. Um, but it's probably, you probably shouldn't be taking that risk on. And if you're going to, you want to be mindful if they have these symptoms, and if they do, you would consider stopping it. Now, patients really don't want to lose their hair, and I empathize. I don't want to lose my hair either. And so I would, would I rather be depressed or lose my hair? Oh, it's toss up, because I'll be depressed if I lose my hair. So I don't know. I think this is, read the article for more information, but just want to make you aware that finasteride can cause that. All right. Here is our next article. Let's kind of see where we are pacing ourselves. I'm probably going to split this up into a couple episodes. So this is slide 3, and I've got 7 slides. So let's look at maybe doing a couple more of these, and then I'll do a second episode. So this is from Saito et al. That is a Japanese name. It's out of Japan. It's called Successful Treatment of 5 Cases of Catatonia Treated with Guanfacine Without ECT, a case series from Psychiatric Hospital in Japan. I found this interesting. The Japanese use ECT a lot. We should probably use it more because it's pretty effective. But for catatonia, benzos are probably the first line. And so in all of these, I read these cases. So these 5 cases, benzos were being used. But they were in hospitals where they didn't have access to ECT, and I empathize. We used to have it in San Diego where I was, and we don't have it anymore. I was in Portsmouth, and they didn't have it anymore, and they had to send people out in town for it. You need, you need a PACU, a nurse, an anesthesiologist that's available to give the propofol or whatever you're going to give them. We talked about this. It's a whole process, and so like not all facilities are going to have access to ECT. And I mean, catatonia, this is probably a patient that's hospitalized. Not all hospitals have ECT available to them, and you can't just transfer some catatonia patient to some other hospital to get ECT and then bring them back. I mean, this is not necessarily easy to do. And so in these cases, they were, I think, going to transfer them to another hospital because they felt like, what we're doing is not working. We need to send them somewhere that has ECT. And for some reason, they thought doing guanfacine, which is this is what, an alpha 2 agonist, right? Isn't this intuitive? I think, which we use for ADHD, right? So you've got clonidine and you've got guanfacine. Those are the 2 big alpha 2 agonists. So as a psychiatrist, that's what you might be using it for: oppositional defiant disorder, ADHD type of symptoms, right? And so like, I'm not even sure, like, this kind of funky that this worked, and I don't know how they came up with this idea. But they talk about it in here in the article. And basically, in these 5 cases, the patient's catatonia resolved. Like, basically, they were giving them benzos. It wasn't doing enough. They felt like they needed ECT. They couldn't get them to, they had to wait for a bed or whatever. And they gave them guanfacine, and they got better. Now, this is not a randomized controlled trial. This is a case series, but guanfacine is a pretty benign thing to give a patient. I mean, we give it to children, it can affect blood pressure, right? Um, so you want to keep an eye on vitals, but if you've got someone in the hospital, they're pretty well monitored, especially if they're catatonic. We're probably checking their vital signs pretty frequently anyway. So, I mean, I would certainly, I think this paper is enough to try something like this. If you're at a hospital and you don't have access to ECT and you've got a catatonic patient and you've tried benzos and they're not working, there's not a lot else you can do. And so why not try this guanfacine? This case series here from Japan had 5 successful cases treated with guanfacine. I mean, that's pretty freaking awesome. You know what I mean? So yeah, this is I don't know. This just kind of blows my mind. But once again, I have case series too, and I'm sure people would be like, where I'm doing stuff that no one else is doing. They're like, oh, it's just a case series. That doesn't mean anything. And it's like, well, probably we can't, just because it's a case series, you probably can't put it in like recommendations, and guidelines and things like that. But I mean, when you've got a case of something and the standard treatments aren't working and the patient's still sick, you've got to do something. And so if you've got a paper out here that says a case series of, hey, use guanfacine, which is like a pretty benign medication, and you've got a patient not getting better, I would certainly think that would be a reason to go ahead and try it. Like, you know, otherwise, and several of the patients who actually had malignant catatonia, which is like the really bad kind, right? I don't think we've talked about catatonia yet. I'm saving that for, it's in the schizophrenia section or series. When we get to that, we'll talk about catatonia. And you've got like a few different kinds of catatonia and the malignant type. So you've got like the I can't remember what they're called offhand. There's the one where you essentially are like very slowed down and not moving, not speaking, but maybe doing some echolalia or some moving your body in a certain ways in response to, like, there's a physical exam findings you can do with this. And then there's agitated catatonia, where the patient is like the opposite of that. They're very active, they're screaming, they're running around, but they're also like still not responsive to your efforts to communicate with them. And then you've got malignant catatonia, where you get kind of their vital signs are out of whack, and there's some thought that it could be related to NMS, right? So, or it could be a form of NMS, or it could be NMS, or something like that. And they actually had a couple of the patients in this series of 5 that had malignant catatonia, and they got better with guanfacine as well. And it wasn't all of them, so it was a mix. And they had, and I don't know how many other patients they treated with this, where they're like 500 other patients that they used guanfacine on, they didn't get better. So like, what, this was just like these 5 patients were going to get better on their own anyway? I don't know. All we know is that they had these 5 cases. So I'd say if you've got no other options, and ECT is something that you don't have access to, just throw some guanfacine on them, see what happens. You never know, and that's where I think a lot of these things from the literature are really important. Is that and I like going outside the box. I like it. I like to personalize my treatments for patients, because we don't have solutions to everything. And when you don't have a solution and you don't know, what else to do, you go out in the literature and you find crazy things that have maybe worked at some point and try them. And the good news is guanfacine is not a very dangerous drug to give someone. So if it doesn't work, it doesn't work. And I think we should do more research on it. So I think I have talked enough today. We went through 3 of the 7 slides. Um, I thought I was going to run through these really fast, but I'm a talker, so um, we will breeze our way through the next 3.5 slides that I have for our November updates on my next installment of November updates quick takes. And I hope you've enjoyed this episode. I hope you learned some things, and maybe you're like, hey, that's pretty cool, I'm going to try that, or I'm interested, that's coming out on the horizon. And I hope you'll join me next time, and I will see you then.